So good afternoon, and it's another week. We're into our, as I call, the fifth 2-week period. It's nearly, it's been 59 days since our last one. So since we started on this path, and as I said, the past 2 weeks are going to be important. The next 2 weeks, of course, are our first 2 weeks of the ongoing school closure and other activities to limit with public health measures, social distancing, as well as people are starting to call it physical distancing, which is a good idea because people are still doing a lot of connecting electronically, and that's great. Keep doing it and doing that. And so we're in this critical time now, as I said last week, as we are entering this weekend. Coming into this week ahead of us is an important one. I noted that we would be seeing the numbers rise as we had more people returning last week and ongoing from other countries outside of Canada. And some of those have been incubating and are getting tested and being followed in that. As you're going to hear the numbers from Dr. Yaffe. I had said that it wouldn't surprise me on the weekend if we went close to 60 and over near 80 in this early part of this week. And that would be part of the numbers of people returning, as well as our ongoing assessments and evaluations. As you're going to hear, unfortunately, with feeling for the families and members and condolences, we've had 3 deaths, and Dr. Yaffe will mention those briefly in that. So that's part of the reality we have with people in risk factors with age combined with a travel history and some with comorbidity or other health care problems are more at risk of the severe consequences of a COVID-19 infection. So it's not something to be taken lightly. We haven't, unfortunately up to now, I haven't experienced a lot of that, but it is a reality, and that's why our directions and issues around really sticking to the home situation, not going out unless you need to, and I'll be talking more about that with the Premier's announcement earlier today, and how we're going to keep trying to ramp that up to make sure everybody continues to do that distancing, which is most essential, and how we might help all of you along with that line. At the same time, understanding people have to carry on with services and functions that are critical, and how do we arrange that? How do we help that such that we can do that in a way that doesn't violate the physical distancing, and so that we can keep COVID-19 at bay in Ontario. So we haven't given up. We're going to keep going at it because I think we can win this one. So let's hear the numbers first from Dr. Yaffe to give you an idea of the ongoing evolution of the situation here in Ontario.
Okay, thanks very much, Dr. Williams. As of this morning, we now have a total of 503 confirmed cases in Ontario of COVID-19. This is an increase of 78 cases since yesterday at 5:30 p.m. So of those 503, 5 were identified through our Sentinel testing. And as I've mentioned before, this is where we're testing patients who are hospitalized for other reasons with severe respiratory illness or respiratory outbreaks in long-term care facilities, where we're just randomly testing, and we are finding now a very small number of positives. In fact, 3 of them were in a nursing home in Halliburton, Kawartha, Pine Ridge. We have, unfortunately, 3 more deaths, making it now a total of 6 deaths in Ontario related to COVID-19. These are individuals in their 70s and 80s who have mostly recently traveled outside of Canada. And in terms of the travel history of our patients in general, of the cases, the 503 cases, 71.2% had traveled in the 14 days before became ill. 12% had close contact with a confirmed case, and 17% had no history of either. As of last Friday, we were aware of 23 patients with COVID who were hospitalized, and of course this number changes every day. And we were aware of 26 healthcare workers who are positive for COVID-19. This is based on the disease reporting system that our public health units enter data into, and it presents a snapshot of data. The fact that they're healthcare workers makes them a priority group for testing. We do not know specifically if they acquired the infection in the community, at travel, or at work. And in terms of the countries where people have traveled from that have become positive, we have basically, again, the United States, Europe are the big sources. Thank you.
Yes, thank you, Dr. Yaffe. And that's an important thing. We still have the ongoing aspect of people who have and up till the last week and continue to return to Canada. We hear lots of people asking to have that be assisted by the federal government, and the message from the Prime Minister was that people from Canada should return home if they can in there. We did hear from on the weekend from our federal counterparts that at least in one of the days across Canada, that means air travel and border crossings, 100,000 people returned to Canada. And again, I said that's on a pan-Canadian basis, so you can get an idea of the numbers we're dealing with in that light. In the point there that we still see the numbers increasing in jurisdictions, as you've heard, and our main concern is, of course, our neighbors to the south as they start to deal more and more with the issue and the challenges that they're facing more in some parts of the states than others, but we still wait to see how the whole aspect's going to show itself there. There had 35,000, they hear heading over 40,000 cases and over 462 deaths thus far in that. So a lot of our people who have returned from there, some and this is where we really want to be careful with our messaging here, because when you come into Canada, we're following ways that we're doing it in Canada, and we're asking for this social distancing, the physical separation in that. And some come across and say, well, we don't remember this from where we came from in whatever country or from the U.S. That's because you were there. Now you're here in Canada. We need you to do that, especially in Ontario, because it's one of the things we are doing more than others have done. And by doing that stringently over the 14-day period that you're going to be asked to stay in isolation in that, and there may be more regulations and rules coming up from the federal government, but we'll have to wait to be appraised by that by our federal counterparts. We've heard the Prime Minister speaking perhaps of some more measures, and we'll have to understand how that might change things at the border. So for those who are coming back, these are new days. These are new rules. It's a new situation. We haven't faced this before. And you need to take it seriously, because the people back here in Ontario have been taking it seriously. And when you come back in, you need to participate in that, especially over the next 14 days when you're back. As you've seen from and heard from Dr. Yaffe, some who have come back and who probably felt okay have become quite ill and are hospitalized, and unfortunately some have deteriorated and unfortunately have died in this circumstance. So it's not a benign or a non-issue of your exposure where you were, and you don't know the extent of the exposure you have been subjected to in those settings there. So we're worried about your health. You should be worried about your health, and you should be worried about the health of your family, friends, and your loved ones. And so we want to do this together, and we want to help you and support you in that way. So I can't say that strongly enough. 28% of the people, the last one, are from the USA, and that number is increasing as we speak in that regard. I should mention that, of course, the ongoing one that seems to be a bit quiet at the moment is our Trenton group. They are due to finish their quarantine period, the majority of them, on Tuesday. But there are, as you recall, a number that have come into the period over the last number of days have become positive. And so we have 13 total. Excuse me. And of those, 7 are Ontario residents. They will be asked to stay on for 10 days past when they had the onset of their symptoms in Trenton. So they might have been day 1 or day 8 or 9. I haven't got the details, but while the rest can go, some will have to stay there for 10 days further from the onset of their symptoms, which I don't have that data in front of me. So the testing overall, we continue to make progress. We said we hope to be over 3,000 by the start of this week. Yesterday, we did 3,100. So the lab people are working flat out to increase that, try and increase the capacity across the board. We hope to be up to 5,000 by the end of the week in that regard, and to keep taking away from the backlog of tests. And again, trying to make sure the tests are not too delayed in that aspect, but we're still making sure if there's some top priority ones in the eyes of the physicians, the healthcare providers, the healthcare institutions, and others that we see are critical, long-term care residents, we can handle that. As you'll notice, we put out some more direction in far as long-term care and retirement homes. We've asked that people, one, they continue to screen all visitors coming into the institutions. Any travel history in the last 14 days, not to come in. If you're ill, not to come in. If you had a contact with a case that you know that, you should not come in. And as Dr. Yaffe said, we do have issues in long-term care facilities with cases being reported, some with workers and some with the residents. And so this is not a theoretical thing. This is a real challenge we're facing as we try to cordon off and protect this most vulnerable population in that regard. And up to now, fortunately, I can't say for sure, in the future, we have had no deaths in our long-term care facilities or in our retirement homes, and that's a credit to the staff that are trying to maintain those barriers and that screening tools and methodologies. At the same time, they're concerned because some people, because they couldn't come in to visit, were taking these very vulnerable citizens back out into the public sector. And we really do not want that to happen, then bring them back in again, because you're introducing basically people who have traveled outside to come back into the facility. So you need to take their safety really carefully. And I know this is a challenge because you want to visit them and you want to work on that and use electronic methods and other methods. So it's a challenging time. We're getting through there. We're into our second week with the school closure and with other measures there. And as you heard, the Premier's announced some further changes around essential services, non-essential services being closed. And we're going to be putting that list out and trying to ratify that as we speak. So we continue to take forward this very seriously. I've been impressed with the amount of people that are doing it. They may be out in some places. I watched them in some of the retailers that are important, their groceries and food stores, and the vendor, the people managing the cash and that and checkouts are being careful. The people are being careful. They're respecting each other. And I say, well done, and keep it up and keep doing that. We're into this second week, and this is, as I said, these days are important ones to stay at the task and to keep focused, because I feel in Ontario we can not only flatten the curve, I like the term by Dr. Theresa Tam, that we can plank the curve, and I think that's an interesting term. And yeah, I think as Canadians and Ontarians, we can do that because we do respect each other, we do care about each other, and we deal with a strong sense of civil order, and we want to do our best to take, COVID-19 to bring it down to a level and to protect ourselves. So with that, I'm going to open up for questions from media, and thank you for your attention.
Okay, we'll take the first question.
First question comes from Lucas Meyer with News Talk 1010. Please go ahead.
Oh, thank you very much for taking my question. Dr. Yaffe, can you mentioned that the 23 hospitalized, that was as of Friday. So is there an update there? How many people are hospitalized? And can you elaborate, too, on how many of them are in ICU, how many are on ventilators, and exactly where these are popping up? Are they popping up around seniors areas, where, as you mentioned, those who have passed away are in their 70s and 80s? So if you could just if we have any more specifics around just how many are hospitalized, how many are in ICU, how many are on ventilators?
Thank you for the question. I can give you the data that was available to me, which is, as you said, as of Friday, 23 people with COVID-19 were hospitalized. I do have the number that were the cumulative number, which means the total number from the beginning till now, till this morning, was 39 people hospitalized. So that means some of them were hospitalized and are no longer hospitalized. It's a cumulative number. And of those 39, 12 cumulative have been or still are in ICU. We are trying to get better figures, obviously, on current. It's a moving target, and I don't have the number on who are intubated at this point.
Okay, just on my second part there, is it possible to get into kind of where, for the ones who are hospitalized, are they around, coming from seniors' homes? I know that, as I mentioned before, that you mentioned that some of the individuals who have passed away were older, in their 70s and 80s. I'm just curious if these hospitalizations are happening in a particular part of the province or coming from some of those, seniors areas, I guess?
They are primarily seniors. and they are in different parts of the province. It kind of reflects the density of the population in the areas.
That would be correct. We haven't heard of a lot of transfers from long-term care facilities over to hospitals at this time. That's encouraging. So in that, but they tend to be more coming from people who have been assessed in the community and assessment centers and that, and coming into the facilities at that time, as far as we have the knowledge of in there. But we will keep you informed on that as the data comes in.
Next question.
Your next question comes from John McGrath with TV Ontario. Please go ahead.
Good afternoon. The Premier repeated today, and the Cabinet have all said that they are relying on the advice from the Chief Medical Officer of Health. And I'm wondering, public servants don't like to give advice that they suspect won't be followed. What can you say to the public to assure us that you're not reserving any advice that you think might be unpopular or might not be implemented? How can we know for sure that leaders are getting the best advice possible?
Right, and that's a good question, because one of the things I said before that I do is that I gather the information from all the consultants around. Unlike even in SARS, we have a large number of people who are veterans of SARS. We have people who are working in very much training in public health and preventive medicine. We have experts in infection prevention and control that are much more prevalent now than they were in the past. These individuals continue to give input and advice and direction. At the same time, have my staff also. And also we work at the federal provincial territory level with our special advisory committee. So we're trying to work along with each other. So we challenge each other in that sense to say, is this the best advice? Is this what we should do now? Because I said we're continually ramping up. We want to maintain the best protection we can, but we don't want to, as physicians, in that sense, do harm at the same time. So you have to balance that out all the way. So all the time, I'm balancing what I'm recommending to the decision makers, to the minister, and that with based on the best science I've got, the best evidence I've got, and all the input from all the consultants and individuals we work with, and my peers across the country, and of course my counterpart, the Chief Public Health Officer of Canada, so we can be consistent on that. That's what I'm most interested in. Is it evidence-based? Is it supported? Is it functional? Is it going to determine and make a difference? And then that decision goes up with recommendations and how that's taken forward into any type of legislative changes politically in that. So far, I found both the minister and the premier have been most receptive to my recommendations.
Follow-up?
Yes. There are provinces now that have a much lower threshold for public gatherings than the 50 that is currently still the rule in Ontario. Do you expect that threshold to be lowered, or have you already advised the government to do so?
It's one we're continuing looking at. The number in the 50, we're looking at how does one set a number that people would respect, knowing that 50 is the most you ever want, but how are you going to have the 50 and still maintain the physical distance? Our priority is the physical distancing. If you can have, and we want to be sensitive to sometimes some very much tragic life issues. For example, if one has to have a funeral with a loved one passed away during this time, and you have people come, can they come through with separate visitation? So you have groupings. People can be kept 6 feet apart. So we want to try and be sensitive in that area there if people would respect the physical distancing. If we find that people are not doing that, then we may have to be much more prescriptive and go down to small numbers. Remember, we went from 1,000 to 500 to 250 to 100 down to 50, and some have gone down to smaller numbers. Yes, we can go down to smaller numbers, and if we sense, and from our officials, that people are being less than vigilant in that behavior, then we'd have to do that. Of course, then we'd have to make sure how we're going to document that and how we're going to audit that if it was occurring. The more important part is that people would continue to respect the physical distancing. That's what makes the difference. The numbers, if everybody's apart, is not so much an issue, but if that helps us to drop it down even further, then we'll have to do so.
Next question.
Your next question comes from Carly Weeks with Globe and Mail. Please go ahead.
Hi there, and thank you. I just wanted to pick up on something you mentioned, that some residents are being taken out of long-term care facilities and being brought back in. Just wanted to ask you about that. Obviously, that appears to be a concern. So, what are some maybe contingency plans around that and dealing with that?
Yes, we became aware that that was occurring, and we worked quickly with our Ministry of Long-Term Care and had consultations with them, and they asked if I would put a directive out that would do that aspect, and so that's out, to ask they not take people out of the retirement home or in the long-term care facility, because we've asked that group, especially the older age group that have these conditions, not be out in the public setting if at all possible, especially for this past week, the week ahead, and the next 2 weeks. It's a very critical time when there's lots of people coming back, and you could be exposed unbeknownstly to that, and the consequences could be quite severe. So we've asked them not to do that. We've asked also that in the direction that if there are people working in multiple facilities, that they would try to seek to reduce that, or at least have that discussion with your employer so they're aware and can take out limitations, because you don't want aspects that could be in one facility moving over to another one, and where the person may not be aware that they were transmitting that. So these are things that they've asked that through a directive I would put out. And again, we're relying initially on people to respect that aspect, but I think we had to put in some bit more as people were, it seemed in different parts of the province, I've been asked by my medical officer of health to say, you need to do something about this. And because I became aware, as I said before to the previous answer, I get that advice and direction from my medical officers and others, and we seek to put those directions and recommendations forward accordingly.
Okay. We were hearing yesterday about the death of a man in the Kawartha region who has no travel history, and local health officials are saying that they believe this is a result of community spread, which would make it the second death in a week that local health officials say are from community spread. So I just wanted to know what you can say about that, and what the public should know about community spread.
Well, I think we're looking at cases where the local public health unit has been unable to identify a source, that there hasn't been recent travel or contact with a known case. Obviously, they got it from somebody. It didn't come out of the air. So, and we know our health units are working extremely hard to do these investigations. Sometimes you hit a dead end. So I think it's fair to say that, yes, in some small percentage of cases, they have been unable to identify a source, so there may be some local transmission of the COVID-19. And that goes back to the main messaging we have, which is everybody should stay at home and keep social distancing from other people, because it's not just people who have traveled. We don't know who has this virus at this point.
Next question.
Question comes from Athia Raj with Huffman Canada. Please go ahead.
Hi, thanks. My question is about the rate of false negatives. Do you have an idea of what that is? And could you explain a little bit about the case of the Western student back in January who tested negative and then was retested? Why was she retested? And then her results seemed to have come back a week positive. Can you explain a little bit more around that? Like, if somebody does have a week positive, do you tell that individual that they are positive, or are they retested? Thank you.
Okay. Well, that's what we did in the past. We had Dr. Vanessa Allen come in and explain that, and maybe you had missed that media event. So what they were originally doing was a certain type of PCR test. They introduced a more the terminology is a 3-allele band on that one, so I don't want to get too technical, but it actually has higher sensitivity but still strong specificity. So in there, they want to rule out any possibility of a false negative. They found on their original screening test, which was only the one, that it was negative, but then in repeat testing with the National Medical or Microbiological Laboratory in Winnipeg and with their own testing, they said it turned weakly positive. So while that might have been a case where you may not have had any active infection at the time, you may have residual left over from the infection, the idea was to err on the side of caution and call it a positive. As you may recall, that individual fairly quickly became negative and was resolved fairly soon afterwards. And so it tells you that the sensitivity of the test is very high, so the negativity we don't see false negatives in that. And so that was one of our main concerns, that there is what we call high sensitivity, but we also want to make sure our positives are positive, and that's what we talk about, the high specificity that has to be in there. It's not due to other things. So we're confident in our laboratory system, and that was in that evolution back, it's like 3 weeks ago now or 4 weeks ago when we went through that. So we're not seeing the false negatives, and we feel confident in our testing methodologies.
All right, you think you have no false negatives at all?
We have not been. We found that our cross-testing we did originally with the NML, our negatives were their negatives and our positives were their positives. So we feel that, and they're both strongly qualitative or quantitatively proven, and so I have full confidence in their methodologies.
Okay, thank you very much.
Oh, thank you.
Okay, thanks.
Oh, I didn't. Okay, thank you.
That's it?
Sorry, is there another question? Okay, sorry about that. Next question.
Your next question is from Chanel Cole with CP24. Please go ahead.
Hi there. Thanks for taking my question. I'm sorry if you addressed this already. I missed the beginning of this, but just wanted to ask you about the positive case at Mark Haven Seniors Home this weekend. Now hearing that a worker there also contracted the virus. So, what's being done to make sure this doesn't spread around this entire seniors home, and what happens to the workers there that may have already been in contact with that person before they tested positive?
I believe that's the one in York Region, I hope. Well, dealing with respiratory outbreaks in long-term care facilities is something that local public health units have been doing for many, many years. It's part of our traditional work. And so as soon as a case is identified, obviously the cases have to be isolated. If it's a worker, they would be home isolated. If it's a resident, they would be isolated as much as possible. They would be doing active surveillance for anyone with symptoms that might meet the case definition, and testing up to a certain number, and then making sure they're isolated, and cohorting, what we call cohorting the staff, so that you don't have a lot of different staff dealing with the cases. You'd have, as much as possible, the same staff. Closing to admissions on that floor if it affects a certain floor, and increasing disinfection and cleaning, and communication with the families. So those are some of the basic measures that are taken in any respiratory outbreak in a long-term care facility.
And just a follow-up on that, because now we're hearing that you can be having the virus without presenting symptoms, how can you make sure the workers that are there treating some of these seniors at the home who may have some immune problems already are going to be safe and not carrying the virus around?
Well, the health and safety of the workers is obviously extremely important. So we have, sent out directions for that. Basic, depending if they're caring for a patient with known COVID or suspect COVID, in terms of the personal protective equipment, obviously very basic hand washing. They shouldn't go to work if they're sick, if they have symptoms, and if they're not at work, they should be using, staying at home like everyone else.
Next question.
Your next question comes from Mike Crawley, CBC News. Please go ahead.
Hi, doctors. The reported shortage of nose and throat swabs means that some physicians and clinics are having to use other types of swabs, but I've seen some documentation that says those results are going to be, quote, reported with a disclaimer from the provincial lab. So what is that disclaimer? Is it that these types of swabs might miss positive cases?
Well, the fact is that we have received a large order from the federal government, and they have received a very large order of the proper nasopharyngeal swabs. In that is reassuring. So I think that issue should be ending fairly soon as we get them out and distributed. The challenge being is that the nasopharyngeal swab, and that's where your positivity for picking up cases is best. If you start doing throat swabs, and I've seen some pictures of international type swabbing, where they're sort of taking it from the back of the tongue, that doesn't have a very good rate of positivity and pickup. So they're not the best ones that, in a way, as someone asked earlier, that could give you a negative result, not from the testing methodology, but not from the lab methodology, but from the methodology you took the swab from. So we don't really want to entertain that. So therefore, if one gets a swab with a regular throat swab from the back of your tongue, it's not really a good throat swab in that, and it's not a nasal pharyngeal swab, your chance of picking up a small or light infection may not be as good as it should be. So we're hoping to get the proper kits all out and distributed. Now we have a proper volume of those in there. So that would be, I think, their main concern is that it's not as good as the textbook, which is a nasal pharyngeal swab.
If my follow-up could be for Dr. Yaffe, the deaths that we've seen in the last few days, seen reported in the last few days, when I've spoken to some epidemiologists, they suggest that this recent cluster of deaths suggests that the epidemic was spreading more rapidly 2 to 3 weeks ago than the positive test statistics would suggest. What would you say to that?
Well, there's a lot of modeling. There's a lot of people making assumptions based on various things. What I would say is that the number of positives is going up every day, and it's going up more and more. And we know that we're not able to test everybody yet. That there's been a huge amount of work ongoing to be able to test more people. And so we're looking at the number of cases is not the complete number of cases. And so, certainly we are concerned that it is spreading, and that's why we're, putting in more measures.
Okay, next question.
Your next question comes from Marie Helen Rattel with Radio Canada. Please go ahead.
Hi, good afternoon. Talking about the potential spread in the community, when we look at in Toronto, there are over 200 cases specifically. Are you concerned about the speed at which it might be spreading in Toronto? What are your comments about the situation in the city specifically?
Well, I know we discuss this all the time when we're looking at spread. If you're in our way we do epidemiology, if you have cases that occur out in the community, as Dr. Yaffe said, if they didn't travel and they don't recall having contact with a case, then they had to get it from someone. And we're really interested in getting evidence of that, because when you go and follow those up with, and it takes sometimes quite a bit of detective work and a lot of time on public health, and you find them on their close contacts, because remember, this doesn't spread casually, it's more in close contacts. And you may find that if you find 3 or 4 other people who are symptomatic, you test them, you know, their contacts, and they each have 4 or 5 others, you have evidence of community spread. And that would be important to document, because you may find it's in a community that you can loculate and close off and deal with a containment type process. So you'd like to know that. So just when you have a case that has no connectivity, that tells me we don't know what's going on, because no one has been able to decipher where the person got it from. If there was widespread, if you find that example I gave you, you could find the person was just an end result of already 800 or 900 people. Therefore, our emergency department should be starting to really ramp up with a lot more ill people coming in. The assessment center should see a rapid increase in ill people, more hospitalizations. So there's many measures to watch that. So because those cases are there, that's concerning. As Dr. Yaffe said, this requires more intensive public health work than they have the time for to deal with all the other ones they're trying to map and follow up with in that. They've already checked out as best they can. The person may say, I don't remember last 14 days. I can't recall what I did on this and that day. And they may inadvertently come in contact with a case that someone tells them. They said, you know, so-and-so, they actually became a case. And so, I didn't know. So it's a good question. We look for it all the time. We are worried about it all the time. We try to monitor it through different methods and through our sentinel surveillance and tools. So all these ones that are out there, either is that the answer is we just don't know because they cannot find out where the person got it from.
More a technical question. I was wondering, how long do people need to wait before they receive the results from their test?
Well, our ideal goal was 12 to 24 hours. As you can see, our testing, we're getting a lot more coming in than we were ready for. We moved up from 1,900 to over 2,500 last week. We said we'd be at 3,100 tests. We did that yesterday. And we continue to open up more and more sites and that. So we're always trying to move up. We got another, like yesterday, we got 3,200 in, and we did 3,100. So the number didn't accrue very much, and that means it doesn't mean that people sit and one test waits for a whole week. You keep moving, the new ones come in, and the ones on the queue get done first. But we always have some that we call jump the queue, and those are high priority ones, as in physician requests for people seen in the emergency department, hospitalized patients, healthcare workers, long-term care, anything related to Indigenous or First Nation communities. These are ones that have major impacts on how one would take a rapid public health measure to contain and control it. So you need to know as soon as possible. So it's a dynamic process, but people usually should not be waiting for more than 3 to 4 days. We've had some people that had waited longer, and we found that the results were sent back to a physician who was no longer on duty that day, and it didn't get communicated, which is unfortunate. So we always have to look at these methods to deal with that, and we would like to try and get the answers back to people in 2 to 3 days, but some may take 4 days, but we would like to really drop that back down again, and we're trying our best to get there.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi there, doctors. I was asking Premier Ford this earlier, and I don't just mean to pin this on the Ontario government because it's happening federally and in the United States and Washington as well. It seems that a lot of governments have only started scrambling in the last week or so, putting up public appeals for personal protective equipment and ventilators and whatnot. And the Premier said today he didn't foresee the spike in cases that we've had. So it looks to a lot of us like the writing has been on the wall for some time. So why do you think governments were not taking these kind of actions sooner, and what were you advising in terms of that?
Well, back when we started this on the end of January, with our first case, we were concerned even then. We were dealing with aspects within our ministry to look at what is our status of our stockpiles with personal protective equipment, with ventilators. We knew we had some in stock. How do we bring some back out, get them repaired? How do we order more? So these things have been worked at now for almost 5, 6, 7 weeks. The challenge that we found out as we got into it more and more is that the suppliers were dealing with an ever-increasing demand, so you're not just ordering on your own volition. You're dealing with a very high competitive global situation, and we keep trying to look for those because a lot of suppliers may say, we can fill that this week, but maybe we change their mind and now we can't, and it's a moving target. So as the issue has greatly escalated globally, as you can imagine, you saw 2 or 3 weeks ago, it was just Wuhan and China mostly, and then it quickly moved into Italy and Europe, and then it just escalated up further. So in a week and a half, things changed drastically. So the the needs were there, the processes put in place to get them, but then the challenges of getting them have even become more enhanced, and you have to look at more creative ways to obtain that, as the Premier's looked at, even having extra ventilators manufactured by some people who haven't done it before but can do so and can bring back pre-purposed things, because with closure of some other facilities, they can then donate and give those to us well that was not available for 5 or 6 days ago. And that's been very encouraging. We find a lot of ones are coming forward with donating unused equipment and donating their time too if it's needed, as well as giving suggestions and ideas how we can handle things, because it is rapidly changing and it's a global change, not just an Ontario or Canadian change.
All right, so you're saying on sentinel testing, Dr. Yaffe, you found 5 people on the sentinel testing. I know that's a low percentage. I'm not sure what your total number of the sentinel tests was. I think last time you told us it was around 2,000, but do you need to be doing a lot more sentinel testing right now?
Well, the total number of people tested through the Sentinel testing is 2,182, so 5 of those are positive. You're right, and that's not the only thing we're doing. We're looking at a system called ACES, Advanced Care I forgot what it stands for, but anyway, enhanced surveillance system, which is through the emergency departments of almost all the hospitals in Ontario, monitoring syndromes, so monitoring for respiratory symptoms and fever, and just ramping this up to report back on suspect cases of COVID-19 in the hospitals. We also are working on a Sentinel practitioner reporting system, which we use for influenza, to add COVID-19 to that system. And then we have the lab data, of course. So we have several different sources of information to monitor the what's going on with COVID-19.
And I would add to that is that as this evolves, those are taken from people who showed up in the emergency department with respiratory influenza-like illness or admitted. And those were happening before, more frequently, before there's a lot of COVID-19 ramp up. Now we have our assessment centers open. We notice our emergency department visits are dropping. And I think a lot of people with respiratory, the first go-to diagnosis is check out COVID-19. And so those ones, of course, wouldn't be part of the Sentinel because they're being tested straight up front, and they're part of our increasing number of tests being requested. So as a result, the number of ones coming in there is diminishing as our outbreaks in the long-term care facilities are more monitored a different way through active testing for COVID-19. There's less demand because they're already tested them COVID-19. We wouldn't do the sample again for that. So I think we're seeing an evolution in the flow of how the clients and the situation in Ontario is changing.
Okay, that's all we have time for today. Thank you.